So without much further ado, I think we have a nice program again this year, and I would like to invite Dr. Chandramouli from the SGH Haematology Department to tell us about the current treatment landscape of myeloma in Singapore. Chandra.
Thank you very much, Viju. Thank you very much to everybody who are here today, sparing your precious Saturday morning with us. This is my first myeloma forum in Singapore, and I've been around in Singapore for about 3 years now. Apologies for my long name, but I believe it is still shorter than my predecessor, Dr. Satish Kumar Gopalakrishnan. So in some ways, it's probably a bit easier for you, for my patients to, and you can just call me Dr. Mouli. Okay, as has been, much of our Singapore Myeloma Forum has been on YouTube videos and stuff. So I've tried to go through some aspects of what has been covered and try and avoid some, but some unfortunately had to be repeated for the sake of patients who have not been there in the previous forums and so on. So let's just start talking about myeloma in general. And this would be the rough agenda that I will try and cover today. So first, what is the scale of the problem in Singapore? How common is it in Singapore? A bit about the natural history of myeloma, what happens, because many times patients come back and ask, what's going to happen when they are newly diagnosed? They're still in a bit of a dark, don't know what to expect in the years to come. So let's try and explore how the natural history of myeloma pans out. I have a very interesting video, which we can stop and start also, about the complexity of myeloma, and that goes to the heart of many of the questions that patients ask me as well. This video was very nicely done by the UK-based cancer charity in UK where I used to work before. And that tries to make you understand a bit more on the concepts of the genetic complexity and why relapses keep happening in myeloma, and a bit on the drugs and survival in Singapore, and specifically, we go to the annual American Society of Haematology meeting, and I'll talk a bit about what is new in the horizon and how have the newer drugs helped. So this is a curve. I apologize for the people sitting in the back if you can't see it properly. So this curve, I would like you to Hello? Can you hear me? Okay, so if you follow these two red circles here, this solid gray line, if you follow that, is the year 2000. And the one on the top is 2017. So myeloma is a disease of elderly, as we all know. And if you see, this is the population of people over 55 to 60. So in the year 2000, there were about 7% of the population who were over the age of 55 to 60. And if you see that in the top red circle, by 2017, that population has already reached the double that figure. It's about 14% of the population now. So that's one aspect. Second, these are the age standardized death rates across different countries, developed countries in the West and here. And you can see Singapore is one that has significantly dropped the death rate from way back in the 1990s to around 2010. It's probably got one of the lowest death rates in the world. So these two put together makes a good chance for lots of older people to be among the mix in the population who are unfortunately the people where myeloma is going to strike. So going forward in the future, we're going to see unfortunately more and more myeloma patients. So how is it in Singapore? As you probably all know, lymphoma is a tumor of lymphocytes, which is a type of white cells. And among them, B lymphocyte tumors are the most common ones, even in the East here. And diffuse large B-cell lymphoma is a type of B-cell lymphoma that is the commonest type of lymphoma. And if you see next to it immediately, though myeloma is a tumor of plasma cells is the most developed form of B lymphocytes. And it's second only to this most common type of lymphoma as a tumor among the B lymphocyte tumors. In Singapore, we know roughly we have about 120 new patients of myeloma per year. That is the number of patients we deal with. These are new patients diagnosed every year. But of course, about 10, 15 years ago, the survival of a newly diagnosed myeloma patient was probably only about 3 to 5 years. Now the survival has gone up and it is closer to 7, 8 years, and probably even longer for the less severe myeloma patients where the genetic lesions are not so adverse. So that leaves us with an incidence of about 1.8 to 2 per 100,000 population, against compared to some of the Western countries like US, where it is much, much higher. It's about 3 to 4-fold higher. And we see that because of this population that is aging, as I showed you in the last slide, we expect about 5, 10 to 15 new patients on an increasing basis every year. This term I will try and explain to you later. We often talk about progression-free survival and overall survival. Overall survival is the length of time that a patient diagnosed with myeloma lives, and that is going longer and longer, and hence, though there are only 100, 120 new patients per year, it accumulates, and over a period of time, you had so much more myeloma patients living. Our median age in this part of the world with myeloma is 64, as compared to the West, where it is a bit higher. And the percentage of different ethnicities having myeloma is roughly mirroring the ethnicity distribution in the country, and males having slightly more commonly affected by myeloma than the females. We all know that myeloma can affect patients' organ systems in different ways. The most common being kidney problems, skeletal or bone lesions, high calcium level, and these distributions are roughly about 1/4 of our myeloma patients develop kidney problem, about nearly half of them have bone problem, and about 15% of them have high calcium in the blood. So that's to tell you a bit about the flavor of how the proportion of myeloma is and how the distribution of disease affects by the myeloma pans out in Singapore. This no myeloma meeting that we go to happens without showing this curve, and I tried to explain this a little bit. Now, over on to the left of this is what we call as MGUS, or smoldering myeloma. So these are patients, and I probably wouldn't expect any of you guys to be in this stage, because this is a very early form of myeloma, if you can put it that way. MGUS means that the abnormal protein that we talk about in the clinics, every time you come, the protein is there in the blood, but these patients do not have any of the myeloma-associated problems. So they do not have kidney problem, they do not have any bone, the so-called holes in the bone, or they don't have anemia, they don't have any changes in the blood count. So all we can find out how this patient have this abnormal protein is by doing the blood test, and we find that the patients have this abnormal protein in the blood, that's all. So they are essentially normal. Smoldering myeloma is a little bit more than that. They have a higher level of the protein, or may have subtle changes that suggest that they are getting towards being a myeloma patient. This is where most of the patients get diagnosed, active myeloma. Now, what happens when we start treatment is the protein comes down, which kind of mirrors what is happening in the bone marrow. Obviously, the cancer cells or cancerous plasma cells are there in the bone marrow. That kind of mirrors what happens to the protein, and hence the disease is inactive at this stage. Now, this is what we call as progression-free survival. So this is the stage where the protein is at the lowest it can become, with the treatment. And after a variable period of time, and that variable period of time is really variable between different patients having different treatments, the disease, the bugger doesn't go away. It comes back. And it does that again and again and again, till unfortunately we reach a stage where we have exhausted all treatments, right? So that's the last, right side end of the curve, where it is refractory relapse. So what people are trying to do is, and I wouldn't want to stress too much of this. This is going to be Prof. Chung's talk next. So there are a few things that people are trying to do. Whether we try and catch hold of patients at this stage, whether it is worthwhile, rather than getting patients at this stage where we know that this is not at a stage where it's going to get away completely and stay away, whether catching patients early at this stage where they're essentially normal and starting treatment early here can make a difference, and whether we can avoid this whole rut of going back and forth with treatment. That is one aspect. Second is whether instituting different ways of treatment and approaches of treatment, whether, for example, maintenance treatment. So the aim is to keep this line like this as low as possible along the way without allowing these to happen. So that is the whole point of different treatment approaches. Trying, for example, the maintenance treatment, it's aimed at trying to keep the patients at this level.
Every day, we're exposed to millions of germs, but our immune system keeps them at bay and protects us from infection and disease. White blood cells form an important part of the immune system. Different types work together to seek out and destroy germs that invade the body. Amongst them, the role of plasma cells is to produce antibodies that specifically tag themselves to that germ. Tagged germs attract other white blood cells. Their role is to destroy and remove the germ. To recognize all possible types of germs, different plasma cells make different antibodies. By deliberately rearranging specific segments of their DNA, each plasma cell makes a unique set of antibodies that only targets one type of germ. Myeloma is a cancer of the plasma cells. Plasma cells can become cancerous when abnormalities occur in their genetic material. One example happens during the antibody-making process, when the DNA is being rearranged. Most have little effect, but some may cause the plasma cell to multiply out of control. Some abnormalities affect the structures in which DNA is packaged. These are called chromosomes. Each cell contains 46 chromosomes arranged in pairs numbered from 1 to 23. In myeloma, chromosomes can be affected in a number of ways. Some involve the switching of genetic material between different pairs of chromosomes. For example, there may be an exchange between chromosome 11 and chromosome 14. This is known as the T11-14 translocation. Others involve part of the chromosome breaking off. This is known as a deletion. Or they may gain an extra piece of chromosome. Some pairs even gain a whole chromosome. This is common in myeloma and is known as hyperdiploidy. Other abnormalities affect the DNA sequence of a gene, therefore altering the genetic instructions it carries. This type of abnormality is known as a point mutation and can happen during a person's lifetime, or it can be inherited from our parents. Most point mutations are harmless, and in fact many we inherit determine our individual characteristics, such as what colour eyes we have or how tall or short we are. However, some genes we inherit may increase our risk of developing certain health problems, including cancer. Mutations we accumulate over our lifetime are more likely to cause myeloma, while those we inherit tend to increase the risk. Identifying the genetic abnormalities in each patient is useful, because they can help predict the outcome of treatment.
Yeah, that's the one.
White blood cell found in the bone marrow. Plasma cells play an important role in the immune system. They produce antibodies to fight the germs that cause infection and disease. Unlike other types of blood cells that come and go, plasma cells stay in the bone marrow for many years. Their job is to remember the germs that have previously invaded the body. Under normal conditions, plasma cells exist in a quiet state. But when a germ re-invades the body, the plasma cells become active and divide to form many copies or clones of themselves. These clones produce large amounts of the same antibody that recognize and remove the germ very quickly. Plasma cells therefore play an important role in generating immunity to infection and disease. Myeloma begins when the genetic material of a plasma cell is damaged but isn't repaired. Damage to genes controlling the cell cycling causes the plasma cell to multiply more quickly than normal. All of the new cells have the same genetic change as the original plasma cell and give rise to a population that are identical or monoclonal. Over time, one or more of the new cells may become even more damaged, and as these multiply, different populations or subclones of abnormal plasma cells develop. Myeloma is therefore not a single cancer, but a collection of different types of the same cancer. Subclones compete for resources within the bone marrow, and some even depend on each other for survival. In the right environment, the clones that survive go on to thrive and allow the myeloma to progress and persist. Treatment destroys some of the subclones, but others may have a survival advantage that helps make them resistant to treatment. Remaining subclones may be dormant for a time and provide a period of remission. However, they will at some point become active again if they incur further genetic damage, or if the environment changes in a way that favours their growth. This is the reason why relapse occurs. With successive lines of treatment, the toughest clones are naturally selected for survival. Those that remain are the ones that are resistant to treatment. Understanding how a patient's myeloma evolves throughout its course will help determine the best treatment for them at that time.
I think you can stop that. Thank you. I hope a lot of that video made sense. If not, we can go through it later again. So this is just to give you a timeline of how the myeloma drugs have been. So up until 1990s, not much was going on other than the discovery about the effectiveness of autologous stem cell transplant, where you transplant patients' own stem cells back into them after a high dose of melphalan chemotherapy. But with the advent of these newer drugs that most of you will now be familiar about, thalidomide, bortezomib, which is Velcade, lenalidomide or Revlimid, things really started to improve. And as I'll show in the subsequent slide, if you see this curve, the red or maroon color, was way back in 1965. And if you see roughly about at the end of 3 years, nearly 70 to 80% of the myeloma patients have already passed on. Whereas if you follow the curve, the solid light blue curve here, which is the most, which is a bit more recent, 2005 to 10, you can see at the same time point of 3 years, nearly 75 to 80% of the myeloma patients are still alive. So that is almost flipped from about 70% of the patients dying to about 70% of the patients living now is a remarkable change. But it has taken us a better part of 40, 45 years to get there. And that is, no doubt without these, effective treatments would not have been possible. So what is happening in Singapore? In Singapore itself, this data shows, this is including, across the board, across different hospitals in Singapore. This solid blue line is the patients who have had autologous stem cell transplant, irrespective of whatever treatment they received beforehand. And this red line is the ones, patients who did not have a transplant. And as you can see, 100 months is about, 8 years? The percentage of patients who had a transplant, about 60% of them are still alive and well, whereas at the same time point, only about 25% of the patients who did not have transplant were there. So this suggests that obviously transplant in our context is also extremely effective form of treatment. This just gives you an overview of different treatments. So we call Velcade and that group of drugs, which are italicized, which are colored here as OMIPs. So these are proteasome inhibitors. They work by affecting a specific pathway within a cell, which deals with, we can call it as a garbage disposal system. So the proteins are degraded by this garbage disposal system, which these drugs block, and hence the proteins that are necessary for survival are inhibited by the availability of things that inhibit them, and hence it's a bit complex to understand, but basically they make the myeloma cells die. With the immunomodulatory drugs, the philosophy of treatment is a bit different. They work on your immune system and make them more able to control the myeloma cells within your body. The antibodies are a more recent kind of entry into the armamentarium of treatment. They go and attack. They work in different ways, but the very simple way to put it is they go and attack a protein that is on the surface of these cancerous plasma cells and thereby destroying them. And you'd be delighted to know that there are more and more classes of drugs that are coming up. Not only newer drugs within the same class are being developed, but we are coming up also with newer drugs of different classes that work by different mechanisms because of the work of the myeloma scientific community. So what's new in myeloma? So we go annually to the annual American Society of Hematology meetings, and we try and learn something new that we can apply here locally. Many times it is combining several new drugs that may not be possible in our context because of cost and other reasons, but sometimes we do time to time come across simple concepts that perhaps we can adopt here. I'll not dwell too much into the first aspect of this, which was increasingly being talked more and more, as Prof. Chung is going to have an entire session on that. I will stress a couple of things about what we call as MRD, or minimal residual disease, as well as whether adding more drugs to the mix is going to get us to better survival rates and so on. And there is increasingly a concept of individualized treatment, which I'll come to, and then a word or two about the newer treatment approaches. So we'll go into the minimal residual disease. Now, at the time of diagnosis, if you see here, roughly most of the patients have 10 to the power 12 cells of myeloma within them. So if you have to put it in the context of numbers, it is about 1 million times million. So that's the number of cells we have in a newly diagnosed myeloma patient. Now, you'll all realize that when we talk about the response, we use the term remission or response, partial response. So that is when say your at diagnosis, your myeloma protein or paraprotein or M-band, as we call it, was say 40 at diagnosis, and after having a certain number of courses of treatment, your protein has come from 40 to 20. That is about what we call as partial remission. So you can understand that even at that point, there are so many issues. Perhaps you had side effects with treatment, but at best, we only achieved a 50% reduction in your M protein. So if you can see here, then the numbers here is come from 10 power 12 at diagnosis to probably about 10 power 10. So we still have more than 1 billion myeloma cells left inside patients who have achieved a partial remission. And if you stretch that further, if you reach a stage of what we call as complete remission, where we cannot find your myeloma protein anymore in your blood with using standard tests, and even more deep remission, we call it a stringent complete remission, where even your light chain tests are normal. If you do your bone marrow test, we cannot find with routine testing any abnormal plasma cells left. You still have got more than 100 million cells left of myeloma in that. It's just that with the best current standard tests, we cannot find that myeloma cells in your body. That doesn't mean that the cells are not there. So the next level is what we call as minimal residual disease. So this is using specialized tests that we now have available in Singapore called flow cytometry, where at about using those tests, we know that there is about 10 power 5 to 10 power 6, so about 100,000 to 1 million cells that are probably left. And even that, achieving that stage is a lot meaningful compared to just getting to a complete remission. And I'll go on to show how this has come out in trials. So this is one such study that was done in France, and if you see, these curves represent survival of different group of patients. So if you pay attention just to the blue and the solid red curve there. So these are patients who were MRD negative. So when they did the MRD test that I was just mentioning about, they couldn't find, they could say clearly that they have less than 10 power 5 to 10 power 6 cells at that stage. And these two, arms of treatment could be either they received a combination of the bortezomib and Revlimid treatment and an autologous transplant, or they received only the bortezomib and Revlimid treatment without the transplant. So, but whatever treatment they received, they got to a stage where their MRD test was negative. So they clearly did better compared to those, whether or not they had transplant, their MRD test was positive. So it clearly shows that it probably drives home the message that it doesn't matter so much as to what treatment you have. As long as you get to the stage where your MRD test is negative, you do better than if the disease stays on still with your MRD test being positive. So that kind of makes logistic sense. If you still have a lot of disease that is measurable, you don't do as well. This just reflects that in the scheme of overall survival. So the patients in red curve here, overall at the end of 4 years, they obviously, if they're MRD negative, they did much better than if their MRD testing was positive. So how do we apply that in the Singapore context? So this was a study that was started by Dr. Satish called SGHMM1, which NUH and other centers also participated. We, in a smaller scale in a country like ours, we wanted to pick out specific population of patients with myeloma who had a higher cytogenetic risk, and then applied a specific treatment. And many of you, I can see, had participated in the trial, and thank you very much for that. They received carfilzomib, cyclophosphamide, and dex, which is one triplet treatment. And at the end of it, we found that certain patients were positive for the MRD testing, and certain patients were negative. So when in this trial protocol, patients who were MRD positive after the whole treatment went on to have maintenance treatment with carfilzomib, whereas the ones who did not have MRD at the end of this treatment after transplant did not receive it. And we have some early results of this, which we have submitted to one of the meetings. Here you can see that for a patient population which had high risk of myeloma, when average follow-up has been about 1.5 years for them, most patients, progression-free survival was about 28 months, which is not too bad, and is comparable to most of the Western studies. And this is the overall survival for those patients, which is also quite comparable to the studies that we know with this drug have happened elsewhere. And coming to the MRD point, we find this is interesting, although the caveat here is there's very, very small numbers, so we have to be careful about drawing any conclusions here, but maybe this, I do not know if this indicates, this is, the blue curve is the patients who were MRD negative, and the dotted broken red line is the ones who were MRD positive. So perhaps this might suggest that maybe the carfilzomib kind of obviates the difference between your test being positive versus negative. But again, it's very small numbers, and we have to wait for longer follow-up and see if this pans out really as it turns out to be. So again, about 5, 7, 8 years ago, we found out that rather than using 2 combination of drugs, like example Velcade, dexamethasone, or similar combinations, if we add 3 drugs to the mix, 3 drugs is better than 2, and that is compared almost across the board. Using 3 drugs is better than 2. So now increasingly they are suggesting that maybe 4 drugs is better than 3. I don't know how this is going to, where this is going to end. We cannot keep on increasing the number of drugs, because obviously you are going to increase toxicity. But this is just one example of how they did it. Again, it's almost like a proof of concept study, and this is extremely expensive combination. This is what I will call as $1 million regime, and certainly it's not extrapolatable to Singapore. But what is interesting is they managed to show that if you use very effective combinations, what used to be the complete response rates in the order of 20, 30%, they're able to almost double it by adding on the drugs. And at the end of the day, they will argue that combining more effective drugs, even though it's 4 drugs, it is possible. They did show that it's not like patients get so much toxicity that they die when they receive this combination or anything like that. And similarly, this is just combining different combination of 4 drugs versus 3 drugs, and again showed that patients who received 4 drugs lived, had a better survival than patients who had 3 drugs. The other interesting concept that is coming across cancer, not just myeloma, is the use of individualized treatment. And this means that in the video you saw patients with different genetic abnormalities in myeloma. One such abnormality is a chromosome translocation that was shown in the video of 11-14. So a bit of chromosome 11 gets mixed up with a bit of chromosome 14, and you get something called translocation 11-14 myeloma. And what was found was when they were screening for the drugs, this particular drug called venetoclax, which affects a different pathway. None of the pathways that I've shown you for myeloma drugs affect the same pathway as venetoclax. They found that this particular drug worked quite well for this particular subtype of myeloma. So it is evolving over a period of time that maybe all myeloma should not be treated treated like the same. You don't get the same drug combinations, but maybe this is a beginning of an era where we will hopefully see specific drugs developed for specific myeloma patients. It's probably going to take years of work to get there, but at least this is a concept that kind of appeals to the scientific community. This is again, laboring the point, but I probably wouldn't stress too much. This is using another protein on the surface of these myeloma patients. So what is newer? So again, it was delighting to see there was, the different new drugs that were coming. Venetoclax that I mentioned in the previous slide. There were other new drugs, new antibodies, and new approaches to treatment. I was, pleased to be asked about, CAR T cell therapy from some of the patients. So this is a novel concept where you harvest patients' own type of white cells and then genetically engineer them to work against myeloma cells, and then you put them back into patients so that they go and attack the tumor cells. So that is one form of new therapy. It is being piloted around the world, and I'm sure we'll get this in Singapore within the next year or two. Similarly, there are other antibodies where they bring closer. So the tumors are always getting cleverer, trying to get over the treatment that we are giving them, and hence what this BiTE antibody treatment does is trying to bring the cancerous cell, in this case the cancerous plasma cell, together with the white cell which is trying to escape from, combine them together so that allow the immunity to kind of run riot on the cancer cells, and that way get control of the cancer. And lastly, I cannot stress more that we are in a better place in Singapore, because we have the cooperation of all the regional countries under the auspices of the International Myeloma Foundation, which provides us and gives us a platform not for just providing clinical trials and thereby increasing in a huge way the access to novel treatments which otherwise our patients may or may not be able to afford. And this was all of us in a first ever Asian Myeloma Network Summit last year. And it's through platforms like this that we will be able to improve the care for our patients. So it is good to be part of such regional collaboration networks. And I think that's the last slide, and you can see Professor Cheng smiling away there with his youthful face. Probably should ask, what is the secret of your youth? And I think that's my last slide. And thank you very much for your attention.